Good morning, everyone. I'm Shannon from the Arthritis Patient Advisory Board at Arthritis Research Canada, and we have with us Janet Pope. Thank you for coming.
You're welcome.
Janet is Professor of Medicine at the Division of Rheumatology at University of Western Ontario, the Schulich School of Medicine, or is it Schulich?
Schulich, yes.
Thank you. Schulich School of Medicine, Division Head in Rheumatology, and at St.Joseph's Health Care Center in London. Her research is in epidemiological studies in Scleroderma, systemic lupus erythematosus, and RA, including outcome measures, clinical trials, and disease manifestations. You're busy.
I am, and I love it.
And tomorrow you're doing a session on Scleroderma. There is a treatment. You need to know about it. So can you tell us a little bit about yourself and how you're involved in rheumatology, or how you got interested in rheumatology?
Absolutely. So as I was training in internal medicine back in the olden days, I think it was role modeling. And so I do a lot of studies with students because I think you imprint on them in a positive way your behaviors, but also your passions. So I met someone passionate and thought, this is interesting. The diseases are interesting. The patients are stoic and lovely by far and large. And it really showed me that you needed clinical skills, good acumen to make diagnoses, and also the chronic disease management, that I would see people over time and you help to celebrate the triumphs, but you try to be there for medical pitfalls and things that happen along the way. So it was the whole package that appealed to me.
A relationship that's different than, a one-off.
Right, and it's different than the emergency room.
Yeah.
Yes.
Wow. How long have you been involved in rheumatology now?
Well, of course I'm young.
Well, that's what I mean. It can't have been that long. Yeah. You must be fairly new to it.
So I finished my rheumatology in 1991 and then did more research actually in clinical stuff in Scleroderma, did my epidemiology degree, and then started really around 93 and have done clinical care and research and a good marriage between the two ever since.
Oh, that works perfect. So could you elaborate for us on your talk that you're going to be giving tomorrow?
Sure. So Scleroderma, or it sort of stands for tight skin. It has another name that we use medically, systemic sclerosis, but that's hard for patients because multiple sclerosis, it's kind of a scary name and they don't know what it means. So we usually call it Scleroderma. And I think what's really important is that it's actually more common than muscular dystrophy, which everyone's heard of from the Jerry Lewis telethons and stuff. It could even be more common than MS, and everyone's heard of that. So Scleroderma is like the poor, unheard of cousin of lupus. So it's an autoimmune connective tissue disease, so antibodies, lots of bad blood vessel issues, and then laying down a collagen, so scarring up of organs. So it's very systemic the way lupus can be. Lupus can affect the skin and or internal organs. Scleroderma is often Raynaud's, fingers going white and blue in the cold, but quite severe compared to regular people that have Raynaud's. They can have ulcers or even black fingertips, that fingers can actually fall off, auto-amputate over time. Their GI tract is involved in everyone, so problems swallowing and food sticking and needing dilatations, and then lungs, pulmonary arteries, hearts, inflammatory arthritis, you name it. So it's actually very heterogeneous, the way, again, that lupus can be, that we'll talk about later. And the reason I got interested, well, this is rare. It's something where we can learn and really unmet need, help patients. So I was very strategic in choosing to research that area because it was kind of not even on the radar screen back then either, even less so. And really now we have prolonged survival. So of all our diseases in rheumatology, it is the most apt, unfortunately, to do you in, to kill you. So even more than lupus or vasculitis. But not everyone will. Lots of research.
Yeah.
We are survival in some of the organ manifestations has doubled twice since I've been in practice. Whereas something like lung cancer, which everyone's heard of, that's super common, not in this disease, but just regular people having lung cancer, survival hasn't changed at all while I've been in practice. So even in a rare disease, we can be proud that pulmonary arterial hypertension, interstitial lung disease, or scarring on the lungs is somewhat treatable now, and we can make lives better and people can live longer. So there's a lot that I will talk about when I have that session.
Sounds like a bit of a PR problem, which a lot of the, I call them orphan diseases have, that people that more people than you think have them, but nobody knows about it.
That's right, and it is rare. It's 2
Yeah.
in 10,000, but as I say, muscular dystrophy, fortunately for people, is even rarer. But I think it's really PR stuff. So there's sometimes a celebrity whose sibling has something like this,
Right.
and then it gets a little bit of news play. But it is a PR problem.
And frustrating for people that have it.
Yes,
Because nobody
yes.
understands what
Although
they're
then
going
they
through.
have good family networks of getting on the net usually and
Yeah.
finding out information, and there are good websites, Scleroderma Foundation as an example. So there's ways to sort of link in and get the information, and people find the, I'll call them experts, they find the people of interest. Either their doc refers to someone who then refers, or they kind of look people up.
Yeah.
Yes.
Are there many support systems in place for people with
Right,
scleroderma?
so I think it's
Or
highly
online
variable.
mostly?
There's online support. In larger cities, there's often support groups, but again, it is rare. But there's a really neat network called SPIN, which is a scleroderma patient information and internet network.
Oh, wow.
And through that, we're disseminating information. It's not only
Excellent.
multi-site in Canada, it's multi-country. And we're using it as a springboard for doing clinical trials of things like hand therapy, because you really can't easily have a therapist who's an expert in scleroderma when mostly what they see is other stuff.
Right.
And just as a tip, I often say to the patients, because they're so tight and hide-bound, some of the patients, if you see a therapist, say, I want you to treat me like someone that's had bad, deep burns, because they know to move the tissues and kind of push people.
Right.
Yeah, so I give them little hints that way, or I'll write a note to their therapist to help. But there's really neat online stuff, and it's growing, and it's free tools for patients.
Well, and I think it's also for the populations that are remote, where
Yes.
people don't have access.
That's right. And even in big
yeah.
cities, if you're seeing a specialist, sometimes like we've surveyed our Canadian rheumatology population, and the usual rheumatologist in Canada sees 8 to 10 patients with scleroderma. I see 400 or 500 a year, right? So it's, the expertise on the whole area is going to be different depending on who you see, which would be true in any uncommon or rare disease.
Yes, and diagnosis. How about and speaking of diagnosis, is it difficult to diagnose? Do people get frustrated because they've
Yes.
they're having to
Yes.
seek out their own diagnosis?
Yes, absolutely. And it's something, because it's rare, it's not on the radar screen. We can't expect a family physician, a primary care, a nurse practitioner to even much have heard about it. So it's really, in general, someone goes to a specialist because they have really bad Raynaud's and finger ulcers, or because they have swallowing issues, they go to the GI doctor, or they have severe new high blood pressure and Raynaud's and their skin is getting tight, and they see the kidney doctor, the nephrologist. And then from there, they often end up with the rheumatologist, almost like we're the people to guide care, to help in care, and to get them to the right other people, because sometimes it's multi-subspecialty, and other times people are living well with this disease. It's a very broad spectrum.
Right. Lots of them are.
Yes, that's right.
So what are your thoughts on this year's meeting theme, building bridges, and how do you plan to continue that through your practice and
Right.
work?
So I think Building Bridges is such a nice title, because we do silo ourselves as subspecialists, or I'm the expert of the subspecialist in this area, and you can get very siloed. And really, to give holistic, great care to patients and the care that they deserve, you do need bridges. You need other people around. That might be family support, might be a social worker, might be a really excellent family physician or nurse practitioner to work with, and to say, this part's your job and this part's my job. And my colleagues are part of that bridge and part of the network of the highways beyond the bridges. So I really think that the day of doing it on your own, you and the patient together as a team, is not as necessary as having a team that has a lot of people or things around it. And some of that team is Dr. Google. Sometimes just saying, if this, here's a good website to look at. But if this occurs, give us a call, we'll see you back. So even like setting limits or expectations, I think, is part of building that bridge.
Are you seeing a lot more open communication between those team members now that the kind of culture of practicing medicine is changing because of patient-centered care?
I would like to say I am, and I think that one of my pet peeves, anyone that knows me in my clinical practice, is lack of communication. Like, how hard can it be to tell the people in the circle of care what you're thinking? And yet there's issues we forget, other specialists forget to copy to the people all in the circle of care, and which is ignorance on our part. And likewise, sometimes we take for granted in the notes. We did a survey of unmet needs because we might talk about lupus, and what we found was that the Canadian rheumatologists were highly aware that lupus had increased cardiovascular risk, heart attack risk, high blood pressure, more risk factors for those areas. But yet almost all of us, I'll be part of it too, we're not putting that in the notes. So if we're not telling, please screen for or treat more like a type 2 diabetic, this patient that I'm worried about with moderate lupus activity, get their targets of cholesterol and blood pressure and blood sugar the way you might look at a patient with other cardiovascular risk. If we don't tell them, they can't read our mind. So I think tools to build into our EMRs, awareness, division of labor, I'm going to follow the labs, please though get your vaccines by your family physician. Clarifying that can only be good for the patients.
Yeah, I think a lot of patients are, they get disease management fatigue.
Yes.
That they're the ones managing their case and they're trying to make sure that everybody's communicating. But when you have situations where you have brain fog or fatigue, it becomes a challenge and an added burden.
That's right. And you make assumptions that the orthopedic surgeon that I referred the patient to has actually let me know that they were even seen.
Right.
And that should be a normal healthcare assumption. But we do have communication blockages, and I think that it will change over time. And it might change because it's unfortunate, but the patient, the family has to almost advocate. Send this to everyone. This test is ordered and I want it to go places, or I will try to be a custodian as a patient of my care to make sure that I'm giving whoever needs whatever. But how can they sift through that? Like, that's almost like a health management degree to know.
Yeah, I think, and the patient's going to have to be part of that bridge until it becomes automatic.
Yes.
That's going to be where the push comes for that communication.
Right. And there are better guides. There's my lupus guide, as a for instance, copied in a positive way from the oncology area, where the journey of the patient, writing down what's when, like the usual stuff that someone might put on their iPhone or their electronic gizmo, but also the questions to bring up, because there are certain circumstances where, for instance, I'm always behind, but I'd like to address all the questions, but if they're prioritized, at least we can get through what is important. And then, because my priorities could be far different, I got to know your blood tests are good, your scripts are renewed, your heart and lungs sound good, your joints are good, whatever. But a patient might want to know, how do I actually apply to get a bus pass? That's an important question.
Well, I find if I have them written down, I don't have to try and remember them, then we can get through more things on both our lists.
Right, and I often, my little trick is while I'm talking, I'm answering the question so that later they go, I don't remember what she said because I asked 8 things and she told me 4 others anyway. But on the list, yes, no, please ask your family doc. That this isn't relevant, don't worry. This we should rediscuss, almost like table, because I don't know the answer, prognosis as a for instance. So I try to do that, and I do think that a patient has a not just more satisfying visit, but a better visit.
Well, yeah, it's a team effort to make sure that everything's on track.
But I feel sorry that the patient that has to be the captain, and sometimes the catcher at the back and the manager, it's a lot to ask of a person living with a chronic disease, or being scared or in pain or tired.
All of the above.
Yes.
So in closing, what lifestyle tips do you have to offer with patients with scleroderma?
So sometimes, and I'll broaden it, scleroderma, inflammatory arthritis, and I'll even broaden it to osteoarthritis, connective tissue disease. Say no to people. So protect your time and your energy, because the tank, running on empty, a car will eventually give up, right? So you have to be good to yourself, say yes to yourself first, then consider saying yes to others. Exercise regularly, eat well, and actually have joy and fun. Laughter is a bit of a medicine. So enjoy what you can and manage your expectations, because if you're always disappointed, because of course when you were well and all of a sudden you have won through the energy you had and your whole career plan or your family plan is sort of knocked off kilter, be good to yourself, try to find the humor in it. And those things go a long way. And try to find a doc, either a nurse practitioner or someone, a healthcare provider you can connect with, because the journey's a long one.
It is. It is. Well, thank you so much for your time.
Yes, you're welcome. I
Thank you
enjoyed
from
being
all
here.
the patients that are watching, and will watch the video when we've loaded it up to YouTube.
We just have one quick question.
Sure.
A patient was wondering how they can participate or how they can help build bridges with their healthcare team.
Right. So I think some doctors still are threatened when someone comes in and takes charge, because we've been such a I'm the authoritative figure and you are the patient and you will listen to what I do. So I think depending on the healthcare provider you work with, the things you should think about quite quickly are just basically, I would like to help in my care. How can I help myself? That's a very open-ended question, unthreatening.
That's a really great one.
How can I help
Yes.
myself in my care? What services do you think I should seek out? Or I can get access for some people to my labs, and sometimes they're scary because everything, there's always alerts that are off that we say, oh yeah, it doesn't mean anything, but to you it's scary when you don't know what it means.
Correct.
So shall I get my labs and bring them in? Would that facilitate my care? Shall I always have your card with me so that when I go to other physicians or healthcare providers, the bridge is built that they communicate with you? So little tips like that can go a long way, and I think asking in an unthreatening way will get that authoritative doctor back to where they went into medicine with empathy, mindedness, and will say, sure, here's a couple tips that I think will help you to help me. Yes.
Perfect. Thank you.